a lot for the nice introduction and for the invitation. I'm happy to share our research in computer and robot assisted surgery. So I'm located at the National Center for Tumor Diseases in Dresden. My background is computer science and engineering. I'm not a clinician, but I work together with surgeons since 15 years. And our expertise is machine learning applied to surgical use cases. And let me start with a recent Lancet comment that stated that post-operative complications are amongst the leading causes of death. And if you look at the diagram, they also stated that around 50% are related to surgical error. And there are also a lot of other studies that show the more experienced a center is, the better is the outcome, which is not surprising, but there are also studies that quantify this. And so our main goal is how can we quantify this surgical expertise and make it accessible to machine? And artificial intelligence is one way to do this. So you can provide decision support along the surgical treatment path. So starting with pre-operative assistance, for example, a therapy recommendation in the tumor board, or predicting the outcome or the best surgical therapy based on pre-operative data, for example. Then in an intraoperative setting, you can also predict complications based on the sensor data you get during operation. You can use it to optimize surgical steps and the strategy, or you can, for example, visualize risk and target structures using augmented reality. And in a post-operative setting, you can, for example, predict complications when a patient is in the ICU. So there are a lot of examples, and the overall aim is to improve morbidity, mortality, and of course the long-term outcome. And if you look now in the OR, we have like robots, we have different sensors available, we have patient data, we also have knowledge. It's divided in factual and experience knowledge. Factual is what you can find in books and so on, and experience is the expertise of the OR team that is operating. And in the end, right now, we have a gap between these components. And we try to bridge this gap by using artificial intelligence. So that led to the Surgical Data Science Initiative, which was founded in 2016. And the goal was to involve different stakeholders, starting from universities that are more research-oriented, hospitals, clinicians, industry, to find a roadmap. How can we bring these systems that are developed in research closer to clinical translation? And I will show you today 4 different examples on what we are working on. And we already heard from the previous speakers that if we use deep learning, we need data, and we need annotated data or labeled data. And this is right now one of the major bottlenecks regarding clinical translation. And so in Dresden, and we are continuously recording data in the OR, for example, during robot-assisted surgeries, but also during conventional laparoscopic surgeries. And we also have an experimental OR where we constantly record data, not only in Dresden, but also in other sites. I think this is especially important that we not only have data from one single site, but from multiple centers. And I will show you one data set that we released now, the Dresden Surgical Anatomy data set. It's a huge data set consisting of robot-assisted rectal surgeries, and we annotated 11 different organs or structures, and it can be used for different kinds of machine learning application in this field, for example, semantic segmentation. We also provided weak labels and so on. So as you can imagine, this was a huge effort because it has to be done by clinicians, the segmentations. And it took us 3 years and a lot of resources. We came up with this data set, but you can imagine this does not scale. So we don't have the resources to provide such big or even bigger data sets. So we need to come up with different strategies on how to provide label data. And one strategy I want to show you is we can generate synthetic data that is based on a simulation. And because it's based on a simulation, we exactly know the labels. So where are the instruments, where are the different structures. And here we used recent unpaired image-to-image translation methods to generate realistic synthetic data for laparoscopic surgeries. As you can see here, one example. And we also transferred this to video data because in the end, we want video data that we analyze from, for example, the laparoscope or the robot, and not only single images. And here's an example of our method applied to videos. And as you can see, this is the first step. So everything is available online, data and the code. And the next step is to involve like instrument tissue interactions, to have a physical model behind it that captures different organ, tissue types, and so on. And also in the end, to provide videos with complications, because I mean, this is something that is underrepresented in the data we are acquiring. I mean, it's good that complications don't occur often, but if we want to have a deep learning system that detects or predicts such events, we need also to have this in our training data. Okay, and there are a lot of other public resources online. I'm the co-chair of the Endoscopic Vision Challenge. So if you're working in this field and you're looking for data, please take a look at the website. There are tons of open data sets for different kinds of laparoscopic or endoscopic applications online. And this is one example. So the next example is decision support, and here we are working on methods to predict surgical complications based on multimodal patient data. So we have two scenarios. We have a preoperative scenario where we start with CT images and additional patient data like lab results, and then we use, for example, graph neural networks to predict the outcome. And the outcome can be, for example, the risk of an anastomosis insufficiency. So if the surgeon knows beforehand what could be the risk, the surgical strategy can be adapted. And this is something where we want to bridge the gap between radiology and surgery, and to make more use of the preoperative data we have using artificial intelligence. Another example is to have the complication prediction during surgery. And here we can, for example, use a special kind of neural network called Bayesian neural network. It also estimates the uncertainty in our prediction. And we try to detect so-called searchomic features like the blood, smoke, use of instruments, how long were the steps, the texture of different organs, anesthesia data, and so on. And the outcome should also the risk of anastomosis insufficiency. So these are two examples in that area. The next example I want to show you is intraoperative guidance. And here we are working on navigation systems. So I think you are familiar with navigation. We have preoperative patient data, as you can see here, the liver with a tumor, and the intraoperative scene looks like that. So in the end, the outcome is also dependent on the expertise or experience of the surgeon, because this model has to be right now mentally projected into the surgical scene. And here we are working on methods to provide an augmented reality visualization. So in this case, it's soft tissue, so it's deforming. So in the end, we need a kind of elastic map that adapts in real time to the tissue deformation we have in the intraoperative setting. So our proposal was to have data-driven models. So we use neural networks to learn to predict the deformation based on the intraoperative data. And one example I show you here, this is something where we incorporated like this navigation function together with a phase detection. So the system knows in which phase the surgery is. You can see it here, an example in robot-assisted rectal surgeries. And so the system detects automatically in which phase the surgery is, and depending on the phase, a certain assistant function is started. So for example, at the beginning, to visualize this incision line, and I fast forward now the video, or in another phases to have like these structures. Here you can see it in still images, the dissection plane prediction, for example, or the detection of risk structures. And we are also teamed up with people from technical design to provide like meaningful visualizations, because this in the end is what the surgeon sees, and it has to be meaningful, and you don't want it to be visual all the time, but only when you need it. So there also has to be some kind of human-machine interaction incorporated. And this system, we will start now a proof of concept trial where we have it also during robot-assisted surgery in real time running to have a feasibility study regarding robustness, accuracy, and feasibility. So the last part I want to highlight is a surgical training, because we all know that poor skill harms patients. And we thought also, how can we improve the skill assessment? And the idea was to have like a sensor-based training system. You can see here behind there are methods running that analyze what is going on. You can see it here in this video. And we also incorporated a haptic feedback in the instrument. So if the instrument, for example, gets out of the view, the novice gets like a haptic feedback, and it is visualized how to move the instrument back to the scene. So there are also other feedback mechanisms we are trying right now, and to improve in the end the learning curve. And on the right, you can see an automatic skill assessment. It's also based only on video data. So we use the OSETS scores here for this laparoscopic training scenario, and the system automatically grades based on these scores. So you don't need a surgical mentor beneath. You can use the computer system to give you the scores in the end for this basic tasks in surgical skill training. So in the end, I want to talk about the remaining challenges, and there are still a lot, starting with data. I said in the beginning, one of the major bottlenecks right now is that we don't have large-scale data sources like in other domains, for example, autonomous driving. So I think it's crucial that we find strategies to overcome this bottleneck, for example, by using crowdsourcing to label the data, or by generating synthetic data. We also need multi-center data. So it starts also that we need a kind of routine that hospitals record their data on a daily basis. So data acquisition is also still a big challenge. Then patient security and safety, we need to take this into account. And in the end, we also need methods that can deal with unlabeled data. So, for example, self-supervised learning is still something that has to be researched. We have a lot of heterogeneous data here. I mean, we are working a lot with video data, and we also have additional devices we need to incorporate. So it's not only like in radiology, still or single CT images. It's a surgery with like an 8-hour video with additional data. That's also very challenging for the methods. And the methods needs to be explainable. So there's a lot going on in the field of explainable AI. And then we also need to integrate the systems in the surgical workflow. And therefore, we need also to have access to the devices. So normally it's not so easy to get access because the companies who are selling their devices, it's normally a closed system. So we also need to team up with them to open the interfaces. And then very important, in the end, we also need clinical studies that prove the benefit, hopefully the benefit of such systems, and not only in one center, but in multiple centers. And therefore, I want to conclude with the vision of the OR of the future, which is a sensor-connected environment that incorporates different assistance function depending on the phase of the surgery. For example, a context-aware visualization or prediction of the remaining time or complication prediction, or semi-automatic guidances of the robot, for example, in the camera. So thanks a lot for your attention. I want to thank my team who is actually doing the work that I presented here, and my cooperation partners. Thank you.